So the first specimen is a voided urine specimen from a 71-year-old female. So on low power, this is a voided urine, so relatively cellular. And just on low power, we can appreciate that in addition to the more bland-looking intermediate cells of the urothelium, we do see like larger cells with darker stain nuclei. So this is what we need to screen in the background. So again, let's take a look first of the benign looking intermediate urothelial cell. So these are intermediate cells. The bigger cells is likely to be the umbrella cells. And then we start to see the cells with increased NC ratio and more coarse chromatin and hyperchromatic chromatin pattern. So again, if we compare with the benign looking cells, the nuclei are much bigger and the NC ratio are increased. The chromatin are hyperchromatic and the chromatin pattern is irregular, coarsely granular. And for the NC ratio, we can see individual cell with really high NC ratio looks like this. So this is already beyond 0.7. But we can still see some relatively lower NC ratio cells. These are still high-grade urothelial carcinoma. So whenever we need to diagnose this, the best thing that we can do is to identify those very high NC ratio cells. So these are definitely positive for urothelial carcinoma. And you take a look of the cell around it. If these looks very similar, these are also cancer cells. So for these specimens, you can appreciate that they are mixed benign urothelial cell and scattered high-grade urothelial carcinoma. So this type of pattern is more commonly presented either in the upper tract urothelial carcinoma that was shading to the bladder and then to here, or it can be present in the setting of carcinoma in situ. So in the carcinoma in situ patient, usually the shading tumor cells are more scant. If it is a flankly like a papillary urothelial carcinoma, usually it will shade more cell, a lot of cells. So in the background, we usually will see most of the cell are tumor cell, and we will see relatively more scant benign urothelial component. Yeah, so sometimes in the upper tract or in CIS patient, we only have like less than 10 of these cells, and this is what we need to screen for. So the specimen, we will call this positive for high-grade urothelial carcinoma. So the diagnostic point is to identify cells with big nucleus, hyperchromatic chromatin, coarse chromatin pattern, and increased NC ratio, nuclear to cytoplasmic ratio. So the next specimen, the patient is a 64-year-old female. This is a pleura effusion specimen, and the patient came to our emergency department. And she is actually a new patient here. So she only came to our hospital once and seems to have like a consult for a famous breast surgeon for second opinion. So she has breast cancer and apparently advanced disease. So the clinician sent her to the ER, just need to get admitted to the hospital. So this is her very first specimen of the pleura effusion. On low power, we can already appreciate that multiple these larger fragments of tight aggregates of cells. So on low power, it actually looks like a small ball around the entire fluid. So this pattern is pretty typical for breast cancer. For the breast cancer in the pleura effusion in the body fluid specimen, they can present it either as what we call cannonball. It's like a 大炮, it's a big aggregate of a cell ball, or it can be present as individual cells lining together arranged in an Indian file pattern. So here we find these typical cell ball, like a cannonball pattern. This is very typical for breast cancer in the body fluid specimen. So we've also had a cell block for these specimen. So the cell blocks look similar because this is her very first malignant specimen in the hospital. We just need to confirm that this is coming from the breast. So for the breast lineage specific marker, here we use GATA3 more often. So the tumor cells are diffusely positive for GATA3 in the nucleus. Additionally, because in the patient's clinical note, there is no hormone status at all, so we also perform ER/PR and HER2 on the cell block preparation. So this is ER. We can see it does show strong positive nucleus in around 90% of the cells. So this is considered positive for ER. For the PR, also strong nuclear staining, a little bit lesser cell comparing to the ER, but this is still positive. For the HER2, so we only see like faint, weak, like a membranous pattern, and the membranous is actually not very confluential, and it's less than around 10%, probably less than 10% of the cells. So we would call these HER2 1+, which is negative. So this is luminal type ER/PR positive HER2 negative patient with pleural effusion metastasis. So the next specimen, let's move to the fine needle aspiration. This is a thyroid FNA. So on low power, very cellular, which is good. So we have a lot of diagnostic material. So when we see the background, we do not see a lot of colloid. We only see very scant colloid, a lot of cells, and many of them arranged in these highly complicated papillary patterns. So you see fibrovascular core just on the low power. Additionally, we also see a lot of these flattened monolayer sheets of cells. So on low power, the pattern is typical for papillary thyroid carcinoma. So when we go to higher power, indeed, this is a papillary structure with fibrovascular core in the center. So this is a true papilla. And then we just need to check the nuclear feature, whether these are consistent with papillary thyroid carcinoma. So here we do see that the cells are mostly oval to elongated. If you draw the long axial, you can see they are crossing with each other, and we do see intranuclear like grooves, and then we can identify area. Yeah, so here is a pretty good intranuclear pseudo inclusion over here. So this is a classic case of a papillary thyroid carcinoma, and we will sign it out as TBS category 6. Occasionally, there are some other ancillary features, including multinucleated giant cells, which is not common in this specimen. In this particular specimen, I didn't see any. And rarely, occasionally, we can also see psammomatous calcification, but we do not see it in this specimen as well. So this is ancillary finding. Sometimes you will see, sometimes you won't see. So this is positive for papillary thyroid carcinoma. So let's move to the same specimen but the direct smear. So for this direct smear, it's also very easy to make diagnosis because here you also see prominent papillary pattern and you also see flattened monolayer sheets of cells. And when we go to higher power, the nuclear feature is even more like apparent because for the direct smear, usually the cell will be like a spreading, flattened, so the nuclear will be bigger. The chromatin pattern is easier to appreciate comparing to the liquid-based cytology. Usually, for the liquid-based cytology, the cells will be smaller because these are prefixed. Yeah, and so you find good intranuclear pseudo inclusion in the center. So this is positive papillary thyroid carcinoma. So the next specimen from a 69-year-old male who has a past history of soft palate squamous cell carcinoma, advanced stage, so he didn't receive surgery. He only have CCRT, chemotherapy plus radiation therapy, and there is an increasing, like an enlarged mass in the neck. So the clinician do fine needle aspiration. So on low power, you can appreciate that we do see a lot of inflammatory cells in a relatively like a pus-like, abscess-like background, but we do see keratinized cells also like a mix in the background. So these type of specimens sometimes is very tricky because if we only identify these mature squamous cells and without identify more like a basal, like a immature high NC ratio atypical squamous cells, the differential diagnosis is actually broad. So these can be also inflamed epidermal cyst with these like a keratinized cells in the background. So whenever we only see these mature keratinized cells, we need to be very careful, try not to overcall if we don't have enough cytologic evidence of squamous cell carcinoma. So we have the direct smear, and this is the liquid-based cytology. So for the liquid-based cytology, you can appreciate that the background is cleaner, so the cytology, the cells are more like easy to be appreciate. So indeed, intermediate cells, superficial cells, but without real like a flank typical feature suggests that it is a metastatic squamous cell carcinoma. So in this situation, with only this cyto preparation, I think the best that we can call is that we call this atypical. So we do see a typical keratinized squamous cell, but in a dense, like inflammatory background. So it is uncertain whether this is truly metastasis or it can be just inflamed epidermal cyst. So we use the residual liquid-based like a specimen to do a cell block. So in this cell block, it is very similar. The background is very similar, but you start to see these like more like a well differentiated, but like a very weird keratosis, like a fragment, and with bigger, like a darker cells with like a strange spindle shape. So with these, I think this is getting more like a metastatic squamous cell carcinoma. However, we still do not see like these the very bad like a high NC ratio squamous cell. So for these, I think we can call these suspicious. and we see these suspicious, like a mature but atypical keratinized squamous cell in a very heavy inflammation background. And this is suspicious for metastatic squamous cell carcinoma. So sometimes the cell block preparation can be a good ancillary test to improve our diagnosis. So let's move to the pap smear. So the first one coming from a 75-year-old female. So it's relatively unusual to have the all female for pap smear, but in our hospital it's very common. So for these, like a very old female, sometimes yesterday we talked about atrophy. Sometimes we will see prominent atrophy pattern, so kind of difficult. And for these, you see relatively possibly over maturation and with a quite inflammatory background. And we do see larger fragments of cells, so these could be a repair, like squamous, immature squamous metaplasia type of cells. So because we have a heavy inflammatory background, we will also want to look for a microorganism. So here we start to see some of these like a rounded stuff in the background, and it doesn't show nucleus like squamous cells, but it has like a pear type of shape. And the size is smaller. And for the conventional smear, sometimes it's not apparent, but occasionally you may see the like a cilia. It's not cilia. It's a flagella. Yeah, and you can see occasionally like a smaller nucleus, like a eccentric to these like materials. So these are trichomona. And trichomona use the collagen and the glycogen in the squamous cell to survive. So sometimes you will see they will attach to a small cell like a lysis cells. So for these type of microorganisms, usually when you see it, you will see a lot of them. It won't be just one or two. Yeah, because they are here and they are happily like colonize the area, getting all the nutrition from the from the patient. So you see, so these are trichomona. So this is benign smear but with a microorganism. 阴道滴床. Okay. 60-year-old female pap smear. Low power, it is bad. So yeah, we see these bloody background and we do not see normal superficial intermediate cell component. So we know when we see this degree of bloody background, it is highly likely to be an invasive cancer. So we just need to go to higher power to see what are the nature of these atypical cells. Are they squamous? Are they glandular? So these appear to be most likely squamous cells. So we see a lot of these high NC ratio dark nucleus along with the superficial cells with like a weird looking spindle shape. So this is consistent with squamous cell carcinoma. So it is not so common to see, but just in this week we have 2 cases. Yeah, so sometimes it just come in 1 week and then you wait for 2 months, there's no positive specimen, but this is a squamous cell carcinoma case. So again, the patient never screened, so screening is very important. So the next specimen coming from 75-year-old female, and she already had a past history from the outside hospital of a possible endometrial cancer, and with total hysterectomy. And she has been followed up in the hospital for more than 1 year. And this is not the first specimen that we receive. So at these times, the smear is actually not a cervical smear, but vagina smear. So the purpose of the specimen is for surveillance of the disease. So we have seen the patient multiple times, and so here are the atypical glandular cell. So this is different from what we see, the squamous cell. So for the glandular cell, you will see mostly cohesive three-dimensional aggregates of the cells, and you will see vesicular chromatin prominent in nucleoli. So different from the keratinized squamous cell that we see. So the patient is likely to have a clear cell carcinoma. In the biopsy specimen, we call this high-grade carcinoma likely clear cell because the patient has been already treated. And yeah, so it's actually quite prominent in the background. So for the clear cell, it's not uncommon that you will see naked nucleus because the membrane and the cytoplasm are very fragile. So here you can see these like a sort of like clear cell with more like a vacuolated cytoplasm, but these membranes are very fragile. So if you do a smear, you will see a lot of these like a naked nucleus in the background. But these cells definitely malignant because you can compare the nucleus with the background lymphocyte. So this is more than 10 times bigger. And you also see the polymorphism, bigger, smaller cells, and prominent cherry red nuclei. So this is positive for carcinoma. And we already know the patient has persistent disease in her vagina. So this is positive for carcinoma. So the next specimen, 37-year-old female. So superficial cells, good. The background is clean, so we only need to screen for the precursor lesion. So along the smearing direction, you start to appreciate, okay, they are cells with high NC ratio, seems to be darker stain in the nucleus. So we will go to high power. So indeed, comparing to the adjacent normal cell, so these we would call the chromatin pattern normal chromatia. So these cells, they look like immature squamous metaplastic cells. So those cells can be the precursor of a CO lesion. You start to appreciate that this is more darker staining, increase of NC ratio, but the chromatin are not very coarse yet. You just see like a bigger, smaller cell polymorphism, more hyperchromatia, but the chromatin is not dark. It's not coarse. So along the smearing direction, we have these like a immature squamous metaplastic type of cells, but with hyperchromatia and increased NC ratio. So at this point, because we do not see typical collocyte, so it is likely not a low CO, but because of these hyperchromatic pattern and hyperchromatia, it seems to be like you are now suspicious. Could it be a high CO, like a CIN2 lesion? Yeah. So it's getting quite a lot of them over here. And some of them looks maybe reactive, such as this over here. But here, you can appreciate it's getting darker. Yeah. So the tricky thing about the high CO is that the size of the nucleus of high CO is actually much smaller than the low CO. So sometimes it's not easy when you do the screen. So then we take a look of the other smear over here. Yeah, and then you start to appreciate that they are real, like a very dark cells, coarse chromatin, but kind of small. Comparing to the size, they are actually kind of small. So it's getting there to be high CO. So when we diagnose high CO, in addition to the class of cell, we want to see individual cell. So you see, this is a very good, like a basal type of cells. Increase NC ratio, you only see very scant cytoplasm. The shape of the nucleus is triangular. It's very strange. The chromatin are coarse. So these are what we want to see. So these are high CO. So here again, this seems to be a little bit pycnotic but very dark, and the NC ratio are increased, and the shape is a little bit spindling. And when you identify these looks also atypical, and these also looks atypical. Yeah, so this is a patient of high CO. She actually already had a biopsy. Biopsy is high CO. At the same time, at the smearing, and she also do HPV. HPV is P16 positive. HPV 16 positive. So this is a patient of high CO, and we will call this high CO. Okay, so that's for all the case today.
Thank you.
Thank you.